Okay, so we're going to look at a quick, easy way to assess back with leg pain, help you clear all the serious stuff and guide the patient down the right pathway. This is by no means a substitute for good red flag questioning, clearing of sinister pathology. So the first thing we're going to do, we're going to sort of look at clearing upper motor neuron issues, lesions, that sort of thing. So the first thing we're going to do with Rob is we're going to get him to walk on his heels for me. Good, and then on his tiptoes. Good, okay. Then we're going to sit him on the edge of the bed and we're going to test his sensation, his power and his reflexes. So we're looking at each level of the spine there. So if you just want to roll your shorts up a little bit for me there. So we're going to test dermatomes first. Okay, so this is checking the sensation along the different nerve root pathways. We're going to get a couple of bits of tissue for this. We're going to run it down each side of the patient's legs and you're looking for whether they can feel it and whether it feels the same both sides. You'll be able to see the dermatome chart on the website. Okay, so Rob, if you want to close your eyes for me, okay, I want you just to tell me if you can feel me touching there and there.
Yep.
Feel me touching there and there.
Yep.
Feel me touching there and there.
Yep.
And feel me touching in there and there.
Yep.
There and there.
Yep.
There and there.
Yep.
There and there.
Yep.
Good. Second thing we're going to do is test the myotomes. So this is the muscle innervation, the power at each different nerve root. So first thing I'm going to get him to do, we're going to test both sides again and we're looking for any differences. So Rob, if you can just lift your knee up and touch my hand there, don't let me push you down. Good. And then this side for me, don't let me push you down. Good. Okay, I want you just to try and kick out into my hands here. Good. And relax. And then this one for me, try and kick out. Good. And if you just bring that leg up, bring your toes up towards your head for me. Don't let me push your foot down. Good. And don't let me push your big toe down. Good. And then try and push me away. Good. And the same with this one. Try and push up into my hand there. Good. Push up there. Good. And then try and push me away. Good. So power's the same. We can move on now to the reflexes. So reflex hammer for this. The most common two to test is the patella tendon and the Achilles tendon reflexes. There are a few others you can test which you can see on the website. So nice and relaxed for me, Rob. Yep. Okay, we're just going to test your reflexes. Good. And we're looking to see, one, compare both sides. We're looking to see if the reflexes are diminished or they're increased. I'm just going to test this side. Good. And then if we just test the Achilles there, just relax there for me. Good. Good. Okay, lovely. Also, in this sitting position, we can look to clear any hip pathology. So, is there any structural pathology at the hip, osteoarthritis, that may be producing these symptoms as well? Nice quick way to do that is to test the internal and external rotation at the hip, medial lateral rotation. Okay, and we can do this in sitting just by rotating the leg there and there. So external rotation, internal rotation of the hip. And again, seeing if that reproduces the patient's symptoms at all. And we can just test both sides, compare the movement and whether it brings on any pain. From there, we can get the patient lying on their back. Okay, so still looking to clear sort of upper motor neuron symptoms. We're going to come down to the end of the bed and we're going to test what we call a Babinski reflex. Using the other end of the reflex hammer or another sharp object, pen, something like that, we're going to run it along the outside border of their foot up to the middle. Okay, and a positive test would be what we call dorsiflexion of the great toe, extension of the great toe. So essentially a positive test would be that toe going upwards. Okay, and all we do around the outside border and we just test along there. And again, we compare both sides. Once that's clear, we can test what we call clonus. Okay, so clonus is a reaction of a muscle to produce sort of repeated movements. The way we test that is just a forceful dorsiflexion at the ankle. So into this position here, and just put it up. And again, we can test this side as well. Good. Then the final thing I'll do in this position, okay, is just test the pulses. Okay, so we want to clear any vascular source for this leg pain. So you can test your dorsal pedis pulse on the top of the foot, and again comparing both sides. And then you can test your tibialis pulse, which is just sort of inside the leg a little bit more there. Good. At this stage, you might like to sort of add a passive straight leg raise as well. However, if you've cleared all the above, so you've cleared your dermatomes, your myotomes, your reflexes, you've cleared your Babinski, your clonus, and you've checked your pulses, and you've also checked your hip range of movement and symptoms, then we've ruled out sort of any source of upper motor neuron, vascular or hip pathology there. So we can pretty much say that this leg pain with the back there is either sciatica or a central canal stenosis. To differentiate between the two, you can do that subjectively. So your central canal stenosis are going to be your older patients. The pain's going to come on when they're standing and when they're walking, and it's going to ease relatively quickly when they go into a bent position, a flex position, sitting down, leaning on a trolley, that sort of thing. Your sciaticas will more likely be your younger patients, and probably won't be eased with bending activities. At this stage, so they've got leg symptoms, either sciatica or central canal stenosis. The first thing we want to do is manage their pain relief, and ideally start them on anti-neuropathic medication to sort of resolve the neurogenic symptoms there, and then refer to physiotherapy, where we can start sort of a structured rehab program for them. Aside from leg symptoms, if you've got a patient just presenting with sort of mechanical back pain, just pain in sort of the central back to the right or the left, what we want to do there is, once all this is cleared and you've cleared sort of your red flag questions, any sinister pathology, get them referred to physio as soon as possible. Ensure that they've got adequate pain relief, advise them on managing their aggravating activities, but do advise them to keep moving and keep working if they can, if there's an option for light duties, that sort of thing. And give them some of the information. You'll find the information on the website. It's important that these patients go away with something to read, something to settle their minds, and then get them to refer to physiotherapy. So just to summarise, we use our dermatomes, our myotomes, our reflexes, Babinski and clonus to clear upper motor neuron signs. We check our pulses to clear the vascular. We can check hip range of movement through medial rotation and lateral rotation to clear hip pathology. If all those are cleared, it's likely to be sciatica or central canal stenosis. Anti-neuropathic medication and refer to physiotherapy. If they've come in with just back pain and you've cleared red flags, sinister pathology, manage their pain with pain relief, advise them on aggravating activities, but keep them working and keep them moving. Give them something to go away and read, which you can find on the website, and get them to self-refer to physiotherapy.